Hi, good afternoon, everyone. My name is Chunta from Singapore. So welcome to the APSC Cloud seminar on cardio oncology. As we all know, cancer therapy has indeed made remarkable progress in the treatment of various cancers. So we are seeing more and more of this cardiotoxicity as well as cardiovascular complications of cancer therapy. Therein lies the dilemma of whether to treat or not to treat all these agents. And it is crucial for us as cardiologists to recognize how do we prevent, monitor, and manage cancer therapy-related cardio dysfunctions. In this webinar, we will delve into several critical topics, and that includes the world applications of cardiac magnetic resonance and echocardiography in monitoring early-stage breast cancer patients, the impact of modern radiation techniques on breast cancer outcomes, the relationship between immune checkpoint inhibitors and myocarditis or myopathy, exploration of the cardiovascular effects of CAR T cell therapy, as well as an overall overview of cardiovascular toxicities in patients who are using antineoplastic treatment. During the next 2 hours, we'll have engaging discussions as well as insights from our expert speakers. And once again, I would like to thank all of you for joining us as we embark on this important journey to understand and improve the cardiovascular health of cancer patients. And I would also like to introduce my co-chairperson, Dr. Chang Wei-Ting, from the Tainan, Taiwan. She's an attending physician at the Department of Cardiology, Chimay Medical Center, and associate professor at National Sun Yat-sen University. She'll be chairing the session together with me. So just some housekeeping matters. The content of this webinar is copyrighted by APSC and should not be distributed without prior permission of the APSC. And the views and opinions expressed in the webinar are those of the faculty members and do not necessarily represent those of the APSC. And this content will be made available via APSC Cloud, Facebook, and YouTube page. And without further ado, I would like to invite our first speaker. Our first speaker is Dr. Pontera Sapalao, who is clinical instructor, Division of Cardiology, Department of Medicine, at the Faculty of Medicine, Sivaraj Hospital, Mahidol University in Bangkok, Thailand. She'll talk to us about serial cardiac MR or 2D echo in prevention and monitoring of cancer treatment-related cardiac dysfunction in early-stage breast cancer. Dr. Pontera, please.
Thank you, Dr. Chunta. So, I would like to share my slides. And good morning and good afternoon, everyone. Today I would like to present the first topic in the serial 2D echocardiogram or cardiac MRI in prevention and monitoring of CTRCD in early stage breast cancer about the role of global longitudinal stain and diastolic function and cardiac MRI. So when we let's start, we should know about that the risk factor of cardiovascular disease and breast cancer. You can see that the many people who have the breast cancer have the cardiovascular risk disease and they will share the risk factor. So when the people who have the breast cancer have the should find out about the cardiovascular disease, about the baseline cardiovascular risk factor, such as age, sex, genetic, and previous cardiovascular disease, and more about the medical cardiovascular risk factor. So it may be that in the baseline, before you go to the breast cancer therapy, you should do about the ECG, transthoracic echocardiogram, and cardiac biomarker, or maybe the cardiac MRI for the previous baseline cardiovascular risk. And the second, that the type of cancer, especially breast cancer, who here have maybe share about the risk of cardiovascular disease and the breast cancer. And the third is the cancer staging, because when the breast cancer is more progression, the therapy from the breast cancer may be about the harm, may cause the harmful to the cardiovascular disease. And the third, that the cancer therapy, breast cancer therapy, especially chemotherapy, about that doxorubicin or maybe trastuzumab and radiation can cause the cardiovascular risk factor. So in the breast cancer treatment and cardiovascular effect can cause the CTRCVT about the 5 or the 5 factors that in about the CTRCD is the most frequent CTRCVT for the risk for the disease of the breast cancer treatment. It can cause about the heart failure and left ventricular dysfunction. So the cancer treatment in the breast cancer is maybe that the anthracycline, especially doxorubicin, and the second is the HER2 receptor therapy, that trastuzumab, and maybe that when the patient have the cancer staging, that maybe that left radiation therapy in the left breast cancer, especially in the left breast cancer, it can cause more side effect in the cardiovascular disease. So when you see that about the breast cancer survival and cardiovascular mortality in all the patients who had this factor in the epidemiology at the chemotherapy is about 42%, radiation therapy 61%, and hormonal therapy 61%. You can see that in the first graph at the left hand, you can see that the overall mortality, that when we are follow up about the patient, you have that in the patient who without breast cancer maybe have the lower overall mortality. But in the patient with breast cancer, when we look at the cardiovascular disease mortality, the patient who have the breast cancer has higher cardiovascular mortality more than the patient who had not about the breast cancer is statistically significant. So in the early staging of breast cancer, patient had the particular risk to improve survival rate, but they maybe have the potential in the late onset of cardiac complication. So it's very important for the early detection and monitoring in the patient who has breast cancer for prevent the irreversible cardiac dysfunction. And this time when you look for the guideline, ESC guideline for cardio-oncology, the breast cancer therapy and cardiovascular screening and monitoring is very important. Besides that, at the anthracycline, you should look for the baseline cardiovascular disease and the baseline cardiac investigation such as the ECG, echocardiogram, and maybe the cardiac biomarker. And the HER2 targeted therapy, we will done that in the baseline and the follow-up for the monitoring. And the radiotherapy is very essential for done in the echocardiography for detection about the baseline cardiovascular disease. So the cardiac imaging is very important for the screening and monitoring the cardiovascular risk factor at the beginning, at the baseline, during therapy, and after treatment for the patient survival after breast cancer. So that's why cardiac imaging in breast cancer therapy is very important. The first is in the echocardiography, and the second is the cardiac MRI. Has the role of cardiac imaging for the monitoring in the breast cancer therapy. When you look at this, the circle of the cardiotoxicity imaging is very for the first one at the clinical of the patient, and about the blood pressure, and about the hypertension, type 2 diabetes, and the symptom of heart failure during their follow-up in the echocardiogram or cardiac MRI. And the second may be that in the cardiac imaging, that the echocardiogram may be low in about the 2D and 3D LV ejection fraction for monitoring the LV function. The other side is very important that LV global longitudinal stain. The LV global longitudinal stain may be detected in the subclinical LV dysfunction in the patient who have the breast cancer therapy. And the second and the third, that in the LV diastolic function. LV diastolic function may be the early detection for management that the patient who had CTRCD. And the other may be the LV dimension and LV volume and the RV function. The RV function may be the prognostic value for the detection about the cardiovascular disease in the patient who had the breast cancer. And the new is about the cardiac MRI. And today we will talk in this topic in the cardiac MRI that what is the role of the monitoring cardiac MRI in the breast cancer, in the early breast cancer therapy. The cardiac MRI with the protocol in the breast cancer may be that about the T1 and T2 mapping, native T1 and extracellular volume fraction and late gadolinium imaging, or it's about for the exclusion after cardiomyopathy or the other cardiac disease that can cause in the CTRCD or in about that such as the myocarditis or maybe the previous cardiomyopathy. And in the MRI, cardiac MRI can perform about in the left ventricular stain. The left ventricular stain in the cardiac MRI can be done for the monitoring in the breast, in the cardiovascular risk in breast cancer therapy. Let me start at about the LV global longitudinal stain in echocardiography. In the LV global longitudinal stain, in the early detection of CTRCD, we look in the LV about the longitudinal stain. The longitudinal stain in the echocardiogram, when we measuring from the base to the apex in the apical view and the maintain frame rate at about 40 to 90 frames per second at a normal heart rate. And we focus on the left ventricle with appropriate adjustment. It's about the 2D performance and 2D quality imaging in the echocardiogram. So we recommend use the LV global longitudinal stain. You should look for the same vendor machine and the software version for reduce about the bias with machine bias in the LV global longitudinal stain, and we should compare with the baseline value because that in the individualized for the patient, the baseline global longitudinal stain is in the same in all patients. So we should look in at the baseline before the patient undergo the chemotherapy or radiation therapy before he treatment for the breast cancer, and you should this for the monitoring in the LV global longitudinal stain. And the parameter for detection of the CTRCD that LV global longitudinal stain reduction more than 15% from the baseline, and from the individual setting that the patient can done the global longitudinal stain, and the absolute LV global longitudinal stain is less than 16%. So when we look at in the picture, the global longitudinal stain from the apical 4-chamber view, apical long axis, and apical 2 axis from the echo to the echocardiogram, and we will derive from the software and machine version to evaluate the global longitudinal stain for calculating the LV global longitudinal stain, and we should this for the compare from the baseline. And how about the assessment of echocardiography in the biomarker in the cardiotoxicity in patients who treat with anthracycline, taxane, and trastuzumab? We have the study that in the 81 women who have newly developed breast cancer treated with anthracycline, then followed by taxane and trastuzumab. We show that from the baseline, LV ejection fraction were decreased from the 46.5% to 59%, and this is the significant statistical when we follow up in the study in this patient that LV ejection fraction is decreased from the baseline. And when we look for the global longitudinal stain, the global longitudinal stain from the baseline who treatment the breast cancer therapy, so we do that the global longitudinal stain is decreased from 21% to about the 19% is the statistical significance when we follow up in the patient who had breast cancer and received the anthracycline with taxane and trastuzumab. So when we look for in this study, we look for the sensitivity, specificity, positive predictive value, and negative predictive value for predictor of cardiotoxicity. So in the longitudinal stain, when we use the longitudinal stain is less than 19% in this study, we will take the sensitivity for predict the CTRCD is about 74%, and the specificity about 73%. And the positive predictive value is 53%, and negative predictive value is 87%. So in the longitudinal stain is less than 19% in this study. It may be the marker for the detection about the CTRCD in the cardiotoxicity who had the breast cancer. But when we shoot this for global longitudinal stain with the cardiac biomarker, the troponin T that is high, we will improve about the sensitivity, specificity, and the positive and negative predictive value. So the prediction is maybe good for the detection. And in this study, we will see that the longitudinal stain was less than 19% in all patients who later developed heart failure. So it may be the biomarker for detection the cardiotoxicity. And from the ESC study about the stain-oriented strategy to the cardioprotection initiation in breast cancer, we can use about the global longitudinal stain for monitoring about the treatment of the cardioprotection. In this study, we see that the 116 breast cancer patients who have standard protocol with the about in the anthracycline with plus cyclophosphamide and following with the taxane and trastuzumab. So we'll show that at the end of treatment, we will look at the LV ejection fraction and LV global longitudinal stain. In the patient who had a subclinical CTRCD, we will see that in the patient who received anthracycline and at the end of the trastuzumab is decrease in the LV ejection fraction in the significant, and LV global longitudinal stain is reduced statistical significant in this patient. But when we use the global longitudinal stain for follow-up the patient in this time at the baseline, the LV ejection fraction is about 60% and the global longitudinal stain is about 19.9%. When the patient, after the patient received the anthracycline and trastuzumab, the patient developed of the subclinical CTRCD, the global longitudinal stain is decreased from the baseline is about 28%, but the LV, you can see that the LV ejection fraction is reduction less than the global longitudinal stain. It's about the normal LV ejection fraction, but we lost about the function of global longitudinal stain. So in this study, when we detect the subclinical CTRCD, so we can look after the cardioprotection and the patient have the cardioprotection and receive the medication, and after the trastuzumab completion, after the patient received the cardioprotection, the LV ejection fraction have improved to the 60% and global longitudinal stain have improved to the 18.9%. So in this study, we can conclude that the effective of the monitoring of LV global longitudinal stain for monitoring and for the monitoring in the treatment and monitoring in the CTRCD in the subclinical patient who received the chemotherapy. And after that, maybe the follow-up, the treatment in the cardioprotection, we can use the speckle stain in the assessment of the left ventricular response in the therapy in the cardioprotection. At this study, we will show that in the baseline who have the baseline delta global longitudinal stain is over than 11%, that can conclude that the patient have the CTRCD. So in the patient who treatment with the beta blocker and the patient who have not the beta blocker, when we look follow up for the result, we choose the global longitudinal stain for monitoring that the patient who have the beta blocker had a significant change from the follow-up at follow-up 1 and the follow-up 2, that he or she will improve in the global longitudinal stain in the patient who had beta blocker, and the global longitudinal stain who the patient who have not received the beta blocker is not changed in the statistical significance. So we can use the speckle tracking global longitudinal stain for detection and monitoring after the cardioprotection treatment. And let's see the diastolic function. The diastolic function may be the early detection in CTRCD, so when we use the echocardiogram at the baseline, patient in early breast cancer who underwent chemotherapy and radiation therapy. So we should comprehensive assessment in the LV diastolic function at the baseline, and we can use the diastolic function for the monitoring. So when we should complete the assessment evaluation of the LV diastolic function, and but the diastolic function may be some factor that can affect about except in the CTRCD, but because that may be the factor that the diastolic function may be affected by the chemotherapy treatment, such as in the volume status patient, when the patient may be the fatigue or he or she may have the nausea or vomiting. Also that the diastolic function may be the factor for detection in the CTRCD, but it may concern in the some side effect from the chemotherapy that can we change the LV filling pressure, especially the E over E prime in the volume status of the patient. But if the patient have the status in the uremia and he or she can have the diet and have appetite, I think the diastolic function is maybe the factor for the early detection of CTRCD. And we have some try that in the change the LV diastolic function in the patient who had the breast cancer therapy. At this time, in this study, we show that the patient who had the 3 drugs in the treatment of breast cancer therapy, in the blue line is about doxorubicin and trastuzumab. In the green line is the patient who has received the trastuzumab and doxorubicin, and in the purple line in the who received both doxorubicin and trastuzumab. When we follow up the diastolic function from the baseline in the E prime average, we will see that from the baseline treatment, the E prime had significant increase in the overall group of the treatment, and in the change in the EA, that when the patient who had the chemotherapy in the 3 group, the EA is increased from the baseline. Is meaning that the patient may develop that the normal diastolic function to the abnormal relaxation. So it may conclude that from this study that the chemotherapy, it may change the diastolic function. And in the Kaplan-Meier from this study, when we concluding in the patient, that the proportion of free-form E prime over than 14, that represent that the patient had the abnormal diastolic function. That when we follow up the time from the patient who received the chemotherapy, the free-form the E prime more than 14 is decreased, and the proportion from the abnormal diastolic function is so that there may be the worsening the abnormal diastolic function. So in this study, we conclude that when we follow up the patient who received the chemotherapy from breast cancer treatment, the diastolic function is worsening. And at this, the echocardiogram, we show the case scenario that the 41 years old woman who had CA left breast state T2N1 M0 status post-surgery, and she had the docetaxel, trastuzumab, pertuzumab for 4 cycles, and doxorubicin and cyclophosphamide for 3 cycles. And pre-trastuzumab therapy before the treatment, that LV ejection fraction is about 68%, and LV global longitudinal stain is -27.5%, and normal diastolic function. And when we follow up after the starting trastuzumab 6 months, LV ejection fraction is reduced to 52%, is reduction in about more than 10%, and LV global longitudinal stain is decreased to the -19.9%, is reduction more than 15%, and the diastolic function is progressed to grade 1 LV diastolic dysfunction, but the patient have no heart failure symptom. It's in the subclinical CTRCD. So in this patient, I prescribed about the ACI therapy, and after the ACI therapy and after starting trastuzumab for 12 months, the LV ejection fraction is improved to 56%, and LV global longitudinal stain is increased from 19.9% to -22%, and the diastolic function is to the normal diastolic function. So in this case scenario show that a global longitudinal stain can use for early detection and monitoring treatment in the patient who have subclinical CTRCD. And the next in the low of cardiac MRI in the breast cancer patient, the routine use of cardiac MRI in cardio-oncology for surveillance is not feasible, maybe that due to the accessibility and relatively high cost, but it may be the useful tool for identify the change in the ventricular volume and ejection fraction, especially the patient who had the poor quality echocardiogram imaging. It may be the patient after surgical in the breast cancer, they may have the breast reconstruction. So at this time, cardiac MRI is a useful tool for detection the CTRCD, or can be worked up in the other cause of LV dysfunction such as ischemia, myocarditis, and cardiomyopathy. And in the cardiac MRI strain maybe show that in the study that the cutoff value of the myo strain is less than minus 0.17% is for the normal myocardium. And in the study we show that the red line is that the normal myocardium is more than 80%, and the blue line is the normal myocardium is less than 60%, and the green line is the normal myocardium is between 60 and 80%. And you can see that when the follow-up strain in the cardiac MRI, that the normal myocardium is more than 80% in the free survival probability is more than in the other statistical significance, at the same as the onset of heart failure outcome, that when we monitor in the LV strain in the cardiac MRI with the normal myocardium is more than 80%. It have free survival from the heart failure outcome is more than in the other. And in this study, when we show that in the cardiac MRI, in the LV ejection fraction in the red line, and the LV strain, global strain from the cardiac MRI in the myo strain, it average for the overall segment in the myo strain in the cardiac MRI in the blue line. So when the LV ejection fraction is maybe in the normal range, but myo strain in the cardiac MRI will decrease when the patient may be at the risk of the CTRCD. So the myo strain in the cardiac MRI may be useful for the detection of the early CTRCD when compared with the LV ejection from the MRI. It can be prevention and maybe the monitoring treatment in the patient in the early breast cancer. And in this time is the example for the use of fast SENC myostain testing. And this time in the case of 53-year-old woman who have breast cancer and high risk for the cardiotoxicity. The green line is the LV ejection by the cardiac MRI. The red line is the LV ejection by the thoracic echocardiogram. And the black is the percent of normal myostain. That we can see that when the myostain is in the black line is dropped when the patient receive the chemotherapy, but the LV ejection fraction in the cardiac MRI and in the echocardiogram is still in the normal. But when we start the heart failure therapy in this point, and so then that the LV ejection fraction it may be at the least, and the patient show no critical of heart failure, and we use the normal percent normal myostain for monitoring and follow up, and will be improved the myostain function in this patient. So this is the example for the myostain testing in the cardiac MRI for monitoring in the patient who has risk for CTRCD. And about the serial cardiac MRI strain in the cardiotoxicity in breast cancer compared with the echocardiogram. In the relative change, we use that the tracking global longitudinal strain and the feature tracking in the global longitudinal strain in the cardiac MRI compare with the 2D global longitudinal strain that is maybe that is the same accuracy in the detection of CTRCD. That what we can use this global longitudinal strain in the cardiac MRI for monitoring in the early cardiotoxicity in breast cancer, and maybe the confirmatory prognostic measure in the future. And in the conclusion for the monitoring of LV function in CTRCD in the patient who maybe that the echocardiogram is the gold standard for monitoring, but when the echocardiogram have poor image quality, especially in the base reconstruction in the left base, borderline LV ejection fraction, and maybe the other cause causing the LV dysfunction, cardiac MRI may be the low for the detection and monitoring in this patient. So at the summary for conclusion in this topic, serial 2D echocardiogram with LV global longitudinal state and the diastolic function is the first line tool for the detection, prevention, and monitoring CTRCD in early stage breast cancer. And the second serial cardiac MRI is reserved for some cases that need higher precision for the detection and monitoring CTRCD. And if the patient has an unclear result from the LV dysfunction, we use the cardiac MRI for finding the cause of the LV dysfunction. So I will stop it at this topic. Thank you.
Thank you very much, Dr. Ponteva. I think that was a very interesting overview of the use of echo as well as cardiac MR in breast cancer. And as we all know, breast cancer is one of the top cancers in women in our part of the world. And there's also a lot of things of how we do surveillance, how we monitor them for cardiotoxicity. Are there any questions for Dr. Ponteva?
Okay. Yes.
May I have a privilege? Anyone?
Yeah, Dr. Chang. Yeah.
Okay, good. Yeah, very impressive. Actually, you just comprehensively overview all about the strengths in cardiotoxicity. So actually, my question is about the strength. Do you think that strength we should set up a cutoff value so we can evaluate a patient, or we should do it like longitudinally? Like each individuals, we have to follow the strengths and how to change to see if there's cardiotoxicity happen. Thank you.
Yeah. I think when we use the patient, the first thing I should like to follow up the clinical patient, and we will follow up about the ECG at every 3 months and the echocardiogram for monitoring. And I think during therapy is not the problem for the cardiologist and the oncologist, because during treatment the oncologist will be send the patient for the cardiologist for monitoring, but I concern about the after treatment in the longitudinal care, that the after treatment the patient who have survival may be lost to follow up in the monitoring, and this patient who have about the anthracycline therapy may be effect in the long-term management. So I think when we use the imaging for the follow-up after treatment about the every year in the first year is very important for the monitoring patient and detection in the patient.
Thank you.
Okay, thank you very much, Dr. Ponteva. I think in the interest of time, we'll move on to the next speaker, and I have Dr. Chang to introduce the next speaker. Thank you very much.
Thank you. And today is my honor to introduce the next speaker. So it's Dr. Ibrahim Abu Granda from UAE. And he is the Chief Medical Officer from Burjeel Cancer Institute, and also Clinical Director of the Department of Radiation Oncology. And also he is the President of the Emirate Oncology Society Radiation Oncology Working Group. So I think he's the best one to present this topic. It's about cancer effects, cardio effect of modern breast radiation therapy in women receiving systemic breast cancer therapy. So please.
Thank you so much, and good morning from Abu Dhabi, and good afternoon, and thank you so much for this invitation. I'll be delighted to present. Just allow me 1 second until I'm just sharing my screen, and then, okay, 1 second, window, there you go, okay, and then share. Do you guys see my slide?
Yes. Okay, we can see it right now. Thank you.
Okay, wonderful, wonderful, wonderful. So again, good morning and good afternoon for everyone. So I'll be talking about the cardiac effects with modern radiotherapy for women receiving breast cancer. As we all understand, cancer now is becoming more of a pandemic. Lots of families are unfortunately affected with that, and breast cancer being one of the most common, if the most common, cancer that we see, that is unfortunately still costing lives of many young women as well. So with that, this is kind of just a schema about how dangerous radiation can look at the heart. However, how modern radiation have really affected this. So this is my conflicts of interest. I have nothing to declare. So this is the outline of the presentation. I'll be just talking about an overview of the radiation therapy and radiation oncology and the importance of addressing heart toxicity in breast cancer treatment. So because this is for a non-oncologist, this is a very important slide. It's very important to look at why do we radiate breast cancer patients in the first place, right? So and it's very important that many trials have studied and restudied and have found out the value of radiation. But nothing beats when you combine all these trials in an individual meta-analysis of approximately 11,000 women from 17 clinical trials. And we've looked at the 5-10-year outcome as well. And the updated publication published in Lancet showed that actually radiation decreases the recurrence by almost 50%, as you can see very, very nicely in this curve. Not only that, it decreases the risk of local regional recurrence and slightly risk of distant recurrence, obviously because we are treating any residual disease. Moreover, when we look at the mortality, and keep in mind this is old data, but this is in the anthracycline era, which is a very important chemotherapy that is also cardiotoxic, that have changed the schema of breast cancer treatment. But when you look at this data, you see that radiation actually prevents death as well, not only prevents local recurrence. And when you compare with overall mortality, you still see slight benefit for patients who have received radiotherapy on top of their breast conserving surgery. When we look at the any recurrence, as I mentioned, it dropped it by about half. When we look at breast cancer death, it's also dropped it. It also dropped it for node-negative patients and node-positive patients as well. And when you look at the subgroup analysis for all these patients, you can see that almost in all categories of patients did better when they have received radiotherapy as well as breast conserving surgery and radiation compared to no radiation. So what we usually say that it approximately halves the annual recurrence rates in most subgroups. And when we look at mortality, it's interesting to see that actually from the 4 recurrences we prevent by adding radiation at 10 years, 1 death is prevented, which is quite important and a high valuable number looking at the numbers of breast cancer patients in the first place. So the conclusion of this updated meta-analysis is that radiation after breast conserving surgery decreases almost half the recurrence rate. There is an absolute risk reduction that is consistent and varies across all groups, and it decreases the risk from death from breast cancer by 1/6 overall. For every 4 recurrences avoided at 10 years, 1 death is avoided at 15 years in node-positive and high-risk patients. In the setting of mastectomy, where the woman has removed the entire breast, there is also benefit of radiotherapy that we can see in the node-positive patient population. However, it's very important to understand the heart toxicity. There is a very well-defined entity called the radiation-induced heart disease, which is not only cardiovascular or vascular disease. It's actually various cardiac conditions that could happen as a result of radiotherapy treatment from different types of thoracic malignancies, such as in breast cancer, lung cancer, lymphoma, mediastinal malignancy, or esophageal malignancies. This could be from the pericardial or pericarditis. It could be from coronary artery disease, myocardial fibrosis, valvular disease. The risk factors of those really depends on the dose that the heart is receiving, the volume, the fractionation, and the patient-specific factors, which is extremely important. So what is the mechanism of having radiation-induced heart disease? When we have radiation, it varies between, vascular disease problems from a macrovascular to microvascular, also pericardial disease related to the thickening calcifications that happens in the pericardium. It also affects the valvar with regurgitation and stenosis. It also affects the myocardial disease, such as systolic and diastolic dysfunction, and even can cause some conduction abnormality. However, you have to look at historical data. Radiation has significantly improved, and this is a very old way of delivering radiation that thankfully right now is almost obsolete. Yet, unfortunately, some countries still are using these very old techniques. This is where we used to have the woman just lie down flat, and just radiate blindly without looking what's happening inside. We used to take this very, very weak port film, and you can see in this port film, this is the entire radiation field. You can see the breast mount or in the silhouette, you can see the amount of lungs that is irradiated, and you can see the heart and the pericardium and the LED, which lies right there. It's all inside our field. So what is the mechanism of the radiation-induced heart toxicity? We know that radiation can cause DNA damage, inflammation, fibrosis, and vascular injury. It comes from the oxidative stress that happens, followed by early tissue damage, and then late tissue damage reaction, and eventually can cause cardiovascular disease as well. However, we need to look at the advancements that happen in the radiation therapy world. So in the 1980s, CT was introduced, and the CT-based treatment planning became widely accepted. We also started to introduce the MLCs, which are the microleaflets, which are microleaflet collimators that allows us to have a very accurate protection. And I'll show you a figure about this in a bit. So both CT scan and microleaflets have enabled us to reach to the 3D conformal radiotherapy, which became much widely adopted in the 1990s. So the microleaflets are what you can see here on my screen. Rather than having just solid blocks that can't move, now within the linear accelerator head, there is a lot of these microleaflets that can actually move while the beam is on to really modify and adjust the dose that the organs are receiving. IMRT, or intensity modulated radiotherapy, has also been introduced. This allows us to, this is a very also novel and effective way where actually the computer generates multiple plans for us, and in retrospect we can actually look at those and see how can we, by putting a target, you need to keep the heart less than X, you need to keep the breast with more than this, and it allows us to give a very nice dose for the breast. Moreover, now we are using image guidance, which has now become a standard as part of our daily treatment. So rather than treating blindly or using these very old films, now we can actually look and see what's happening. So our machines mostly are equipped with a technique that we can allow to do a CT on the patient to look at what's happening inside the body and inside the heart. We would also allows us to safely protect the organs at risk surrounding it. Not only this, we are using a lot of advancements in our positioning for the patients. So rather than having the patient sit freely, we are using abdominal compression device. We have a very solid, nice body vac lock that allows decrease in motion and decrease in the uncertainty that can happen during radiation. Moreover, very important for breast cancer is the breath hold treatment technique. This is when we ask the patients to hold their breath during their treatments, and this would allow us to really spare the heart and the lungs for a longer to protect the heart as well. For DCT, simulation and respiratory gating is also extremely important, more so in lung cancer treatment, but it's also for protection for the heart as well. So this is very important to account for accurate dose calculation and distribution. When we talk about deep inspiration breath hold, which I mentioned earlier, this is extremely important in breast cancer, and this is a figure to show how important this is. So when we treat the patient, usually our beams are kind of tangential. So when patients take a breath and hold, what happens is you can see that the heart, so this is the original heart position during free breathing scan. What happens is when the patient takes a breath and hold, the heart gets moved posteriorly and inferiorly. So we can safely avoid the entire pericardium actually in our tangential fields. And when women have a good breath hold technique, it really helps us in protecting the heart and decreasing the heart dose. Not only this, we are in the era of really advanced planning and advanced softwares. Now our softwares are able to give us really auto-contouring and cardiac contouring with auto-segmentation. We're not contouring just the heart entirely. Now we are contouring the different parts of the heart, whether it's the right ventricle, right atrium, left ventricle, the aorta, the myocardium, the coronary artery, and the circumference artery, so we can actually have those contoured and reviewed on daily basis with actual dose calculation for planning. So in the modern dose constraints, the mean heart dose should be less than 5 gray. This comes from multiple retrospective and prospective studies that had different types of tumors, and they've looked at when do cardiac events happen, at what dose specifically. So again, this is based on old data. Luckily, we don't see this anymore, but we do see that this is where we got those constraints from. And a very important landmark trial in the radiotherapy world came in the New England Journal of Medicine by Darby. And in this study, they evaluated more than 2,000 women from Sweden and Denmark, again, treated very long time ago. And they have looked at the cardiac events that has happened. And this is in relation to the radiation therapy. And they have concluded that every 1 gray additional to the mean heart dose, there is a 7.4% increase in cardiac events, all cardiac events. And you can see how the risk of major incident cardiac events goes exponentially up higher when the radiation dose goes higher than 5. This is from our own institutional data. We are a small center compared to your respected centers, but we were able to look at all patients up to July 2023. And we looked at the patients who have received radiotherapy, and we've looked at the dose with the mean heart dose and the lung doses for all women receiving either left breast radiotherapy with lymphatics and even right-sided breast radiotherapy with lymphatics, or right-sided breast radiotherapy only, because even in the right side, there is some scattered dose that can come to the heart. And remember that, the pericardium can also be there. So it's very important that we contour this and we report this as part of our daily QA and for our annual assessment to see how are we doing. Luckily and thankfully, if you look at the accepted mean dose, as I mentioned, they said less than 5. We are actually able to achieve almost half of that on all of our patients, with the median going not more than 2.68. So what I'm trying to say is that with modern radiotherapy techniques and very good medical physics and radiation therapists and very solid and strict constraints, you're able to achieve a much lower dose than what you are quote unquote allowed or to allowed to do. Not only this, there's a lot of future technologies and emerging technologies that is happening in the radiotherapy world. Adaptive radiotherapy is a very important concept that's been currently used in clinical practice. It's mostly now in the pelvis, but it is moving into the thoracic. This is not very much applicable for breast cancer. However, it is applicable for a lot of mediastinal tumors, for example, mediastinal lymphomas, that get really good response during treatment. So if you can see, this is an adaptive plan where, the figure on the left shows the tumor initially. And while the patient's getting their treatment, the tumor shrunk by significant more than 50%. So now the new plan, rather than treating the entire red area, which was based on the initial plan, we actually adapt the plan. So technically, the new plan will only target the tumor itself, sparing a lot of lung and heart and pericardium and valves during this process. Moreover, it's important to discuss particle radiotherapy when we're talking about the heart toxicity. Just to remind everyone or introduce the concept, with the regular photon or X-rays, we can see that the energy kind of builds up and then exits, but there is still an exit dose. Electrons, which is another way of delivering radiation, very commonly also, it's very important for superficial and very effective for superficial radiation. Protons, on the other hand, have a relatively low entry dose, but they have what we call the Bragg peak, and then a very low or almost zero exit dose. This is a heavy particle, which is a hydrogen atom, hydrogen nucleus that has been accelerated to almost the speed of light, and it slows down literally where the tumor is and releases all its energy, and then so the exit dose will be very low. This is extremely important in order to protect the heart and other neighboring structures. And this is kind of a figure just to illustrate how protons really look. So if you look at the exit dose of this mediastinal tumor, you can see that the exit dose is almost none, that most of the dose is coming from here, but there is no exit dose. This is with particle therapy. And if you want to compare protons versus the IMRT, and you can see how much with protons when you are having very low or almost zero exit dose compared to IMRT when we're coming from different angles, you can see how much, if you subtract this from this, you can see how much additional radiation or unnecessary radiation the patients are having with IMRT. And this is kind of a nice illustration to see how the progress and summaries between the 1980s with the 3D technique to the 1990s with the IMRT, 2000s with the VMAT, which is a kind of a more advanced and fast way of delivering IMRT, with first generation proton, which is passive protons, and now with the IMPT, or intensive modulated proton therapy, or pencil beam proton therapy. And you can see how the mean heart dose significantly dropped. And this is coming mostly from esophageal cancer trials. Moreover, there is a lot of MRI Linux right now. So MRI Linux is a machine, it's a linear accelerator that is linked with an MRI. It allows us to really visualize the soft tissue, including the heart, the different parts of the heart, while the radiation is on, to really prevent excessive radiation with different brands in the market. So with the MRI radiation, for example, in this patients with breast cancer, you can see how accurate and how easy it is to target the tumor bed while looking at the heart and the different components of the heart and assessing how much radiation is each part receiving and prevent and decreasing those using different angles. So the radiation-induced cardiovascular disease, this is a very nice review that I encourage my colleagues from cardiologists to read, and even I encourage my radiation oncologists to read. And it has a very nice summary and schema, which I'd like to go over. So the clinical manifestations of radiation-induced cardiovascular disease, coronary artery disease is the most common complication and the most dreadful and fearful one. The valvulopathy or valve abnormality, the pericardial disease, whether it's acute pericarditis, pericardial effusion, cardiomyopathy, where diastolic cardiomyopathy more than systolic dysfunction can occur, conduction disorders, right bundle branch block being the most common one. The risk factors is, as I mentioned, the total dose of the radiation, the volume of the heart that is irradiated, concomitant use of anthracyclines, which is extremely common in breast cancer, younger age at the time of radiation. So this is why we really try to look at young breast cancer patients with really extra cautions and pre-existing cardiovascular disease and other cardiovascular risk factors such as hypertension, dyslipidemia, diabetes, smoking, inactivity, and of course family history. Screening for cardiovascular disease for with TTE, CMR, or CT angiography who have received more than 35 gray of radiation, which I would say, luckily, in breast cancer, rarely so. We should not be receiving that, but it could be in other malignancies such as, esophageal cancers or thoracic malignancies, like lung cancer. And this should happen 5 years after the completion, or at the age of 30 to 35 if they were young, or if they have any symptoms. With the management, of course, very clearly and discussed here for my cardiology colleagues. So my conclusions from my talk is that, as we can see, radiation plays a crucial role in the treatment of cancer, specifically breast cancer. It does improve survival. However, radiation-induced heart disease is a real concern. All techniques are associated with increased risk of radiation-induced heart disease. However, recent radiotherapy techniques and advancements have decreased these risks, whether it's with CT or MR guidance, improving positioning and treatment delivery, such as the deep inspiration breath hold, which is very important in treatment of breast cancer, adaptive radiotherapy as well. Auto-segmentation and AI tools are really coming to help us to understand where are we in terms of the different subparts of the heart as well, and what will be the dose constraints for each subpart rather than the entire heart. And of course, proper counseling and patient selection is the key. If we can avoid radiation in patients, for example, we have data now on de-escalation of radiotherapy with patients with complete response after neoadjuvant therapy. I think this is extremely important, and this data should be adapted in order to prevent, because we know that every single centigrade, not even gray, matters for the heart. With that, I would like to thank you all, and I would like to thank the Emirates Cardiac Society for this kind invitation, and I look forward to welcoming you all to visiting us in Abu Dhabi. Thank you so much.
Thank you, and really nice presentations, and really appreciate all this information you shared. I'm wondering, is there any questions from the audience or from the chair or speakers? If no, it might take an advantage. Okay, so actually, I'm really impressed about when you talk about the portents or these edge nanotechnologies. So actually, I'm just wondering if you can give some advice for the like my colleagues cannot share with them about these information. If for radiation oncologist, I think if the toxicity happened, it's just at the beginning when you decide what kind of treatment strategies. So what kind of if you I think it's not everyone can get a portal, yeah. But if any kind of strategy suggests if a radiation oncologist want to give the treatment for a breast cancer, maybe like left side breast cancer patient, what kind of strategy would suggest?
Okay, great. So great question. Thank you for that. Because of the very good patient positioning with deep inspiration breath hold, I don't think proton is a must for breast cancer, except for certain scenarios for patients, for example, with abnormal defect in their chest wall, like pectus exavasum, or where you can't, by physics, you cannot really get the field inside and out without going through the heart, or the patient can't undergo deep inspiration breath hold or something like this. So I would say for the vast majority, standard treatment with forward planned field and field IMRT or 3D techniques with heart and lung block is very well accepted because of the tangents. But in cases for breast cancer, I'm talking about but in cases specifically where there are abnormalities in the anatomy, or the patient cannot do breath hold, or for these reasons where you can see that you cannot achieve a good radiotherapy plan without compromising with either giving more radiation to the heart or compromising your dose, because this is something you don't want to do, then you should shift to different modalities. And it's very important for my cardiology colleagues as well to know that the radiation usually details and documents are really locked, and no one can change them. So and it's very important that I always tell my cardiology colleagues that do reach out to your radiation oncology colleagues and get the radiation records, because sometimes as a radiation oncologist we just contour the entire heart, but you're more interested to see this area of the heart, how much did that received. So this you can actually get in the plan. We will be more and more helpful by providing those with the new era of AI and auto segmentation, where now the softwares can actually draw for us different part of the heart as well.
Thank you. Really impressed. Thank you.
Thank you so much.
Okay, great. So if there's no extra questions, because of the interest of time, so maybe we could move down the next one. Thank you.
Yeah, I will introduce the next speaker. Thank you, Dr. Ibrahim. That was a really enlightening talk about radiation. I think we are going to have more collaborations between cardiologists and radiation oncologists, especially with things like stereotactic VT ablation with photons. It gives me great pleasure to invite the next speaker, Dr. Chang Wei-Ting. She is my co-chairperson, and she's the attending physician at the Chimay Medical Center in Tainan, Taiwan, associate professor at National Sun Yat-sen University. And she's going to talk to us about something that we see quite often with immunotherapy, immune-related myocarditis versus immune-related myopathy in immune checkpoint inhibitor therapy, distinct biomarkers and cardiac dysfunction outcomes. Dr. Chang, please.
Thank you for the nice so actually just let me share my slides. Okay, could everyone see my slides?
Yes, we could see
good.
it. Yeah.
Okay, perfect. Okay, so today actually my topic is kind of long, so actually I just want to shorten it. It will be the immune-related myocarditis in immune checkpoint inhibitor, ICPI, and distinct biomarkers and the cardiac dysfunction outcomes. So actually, I think everybody knows the story about President Jimmy Carter and who got myeloma, and actually because the immunotherapies and she get very nicely improved about the outcome. So in the past, like we think it's not a treatable disease. Currently, it kind of dramatically survival get better. So quickly today I will go through these outlines. Hopefully I can finish all this within time. So let's just quickly introduce about the IO therapy, also called the immunotherapies. And I think most important is about the immune-related adverse events, of course called the IRAE, especially we'll focus on cardiac complications and how to do the early diagnosis and prevention, and what is the updated management. And also at the end, I want to quickly share about our own data about the IA in Taiwan. So I think everybody here knows about the PD-1, the PD-L1 story, because the Nobel Award is story about that this target will be more like the break of the immune cells, like the so the tumor cells and they can have some interaction between T cells and the antigen-presenting cells. Actually, the PD-L1 or PD-1 ligand, or like a CTLA4 ligand, actually will stop the immune response of the immune cells toward the cancer cells, so that the cancer cells can survive. So actually, in the past, there are several different kind of immune therapies that have been proved to treat the different kind of cancer. Like currently, we have this, and all these treatment actually can target a different kind of, like a really large variety of cancer, including like melanomas or like skin cancers or like lung cancer, hepatomas, and different kind of varieties. So, but even the patient can improve about the survival. So later on, we'll find a different kind of story that happened about the side effect. So what is IRA? It's immune-related adverse event. So because the immune response is cannot focus only on certain kind of location, sometimes it's called the overwhelming, immune response toward different kind of systems. So it's called more like the autoimmune response. So including like a colitis or pneumonitis or encephalitis or like a pulmonary embolism or like the ventricular or like the other complications. So the possible mechanism about the IRA, currently we can conclude 4 possible mechanisms, including like either trigger the cytokine storm, which is the most familiar, the possible mechanism. Or the other is that we can increase the T cell activity against the antigens to the healthy tissues, the side effect. And also, if there's a pre-existing autoimmune and the autoantibodies will be triggered. And the other thing, this can also enhance the complement-mediated inflammation response. So all these possible mechanisms can contribute to the IRAE. And some people will say there's a cytokine storm induced by the either like the immunotherapy or by the next speaker will mention about the CAR-T therapies. It's a little bit like the SARS-CoV, it causes the cytokine storm and systemically infect different kinds of systems. So based on the NIH approved, there's grading. So the grading is called the CTCAE, and depends on different kind of systems, like the pneumonitis or like a colitis, and we can use this grade to see this how severe the side effect would be. So from the grade 1 to grade 4. But so today we'll focus on the heart. Even though that's pneumonitis, the lung disease or like colitis is more frequently observed. But actually here we can see even this kind of relatively rare is about 1%, but the myocarditis will be even really fatal. So that's why we have to pay more attention about that. So the cardiovascular complication of the immunotherapies, and actually, I think since we treat more patients, we'll get more case report about like this one is a 41-year-old woman and who have melanoma and be treated with the immune checkpoint inhibitors, and later on she developed like dyspneas and also there's elevated troponin I, but it's some kind of weird because it's different from the myocarditis we see in the past induced by the virus infection, because there's a normal anti-proBNP, and even the ejection is not getting kind of low, it's still about 50%. The coronary artery is normal, but you can see there's myocardial biopsy shows a lot of infiltrated immune cells, and even the cardiac the significant enhancement here. So there's more in the case and be diagnosed with myocarditis and just associated with the treatment with the immune checkpoint inhibitor. So actually, we're not surprised about this or not. So we just go back to the Dr. Honjo's, who won the Nobel Prize about the immune checkpoint inhibitors. And the really early paper he published is about the autoimmune dilated cardiomyopathy in PD-1 receptor deficiency mice. So it's kind of not surprising because if we suppress the PD-1, actually we can find a very similar phenomena about the autoimmune dilated cardiomyopathy in our patient. So this is a proposed mechanism, actually kind of similar to the IRA systemically, but if for the heart, is also contributed by the systemic cytokine storms and all the toxicity. So the other question is about, what kind of complications that we will face. So in addition to myocarditis, the other would be like pericarditis or like a vasculitis, or like systemically will cause like abnormal conductions, even like the complete block or like a 6-sinus syndrome have been reported. So here is just a quick examples about ECG. So we can see that initially there's the AV dissociation, and then later on there's a ventricular tachycardia. And about the lab data, so we make a check the troponin or like the BNP, anti-BNP. So sometimes it cannot increase as we expected. Other tools, including like ECG and also like echocardiography, and later on introduced about the cardiac MRI, because currently it's more like we can do instead of the myocardial biopsy, which is more invasive. And the cardiac MRI will be a non-invasive tool, and we can longitudinally monitor the condition of the heart in the patient suspect with the immunoglobulin-induced myocarditis. But of course, endomyocardial biopsy is still a gold standard about the diagnosis. So the CTCAE grade about the heart, here we still can see that if a myocarditis from grade 1 to grade 4, and actually depends on the severity of the disease. So that's why we can just so grade this patient depends on their disease. And who are at the risk? So next one is even that, especially nowadays, we have more and more patients treated with immune checkpoint inhibitors. And which one will be a possible high risk that we had to do even more close monitored? So this is the paper published about 7 years ago, but I think it's the first one talk about is a patient with myocarditis after immune checkpoint inhibitor treatment. And here it reported that the myocarditis will be happened more frequently in patients with underlying diabetes, sleep apnea, higher BNP, and or treated with melanoma or non-small cell lung cancer. And later on, there's more and more literature come out, like this one calculate. It's a statistic about the 10 years the patient, and they found that if the patient treated with PD-1 or like CTLA-4 inhibitors, and this is about 1% of the incidence which can happen with the myocarditis. But if we combine with these two treatments, sometimes the incidence will increase to the 2 to 3%. And another important issue is about when it will happen. Usually it will happen within about 1 to 3 months after treatment, but some still report, it can happen about half a year. So it still have to be really careful about the patient. If the treatment seems okay, but sometimes later on we still have to do the longitudinal follow-up. The other is about the clinical presentation. As I mentioned, that all these patients have the immune checkpoint inhibitor-induced myocarditis. Actually, the phenotype is not the kind of similar to the virus myocarditis. Like the troponin, it will increase, but not as high as we think. And also about the anti-BNP, only about half of patients have increased anti-BNP, especially about ejection fraction. Some of the patients will have preserved ejection fractions, but still have severe, profound heart failure. So it's kind of new to us. So I think we have to pay more attention about the possible clinical symptoms. So the other thing is about awareness. So like I say that most of the patients will have their symptoms within about 1 to 3 months, but sometimes they'll persist even longer. Especially here, if the patient also have like pneumonitis or like a dermatologic disorder or like a colitis, it could possibly be early sign about the possible happen of the myocarditis. So we can still be more careful about the other possible IRAs, and it will be early sign about the possible complication to the heart. So how to screen? Actually, several possible proposals have been raised. So still to the biomarkers like troponin or like anti-BNP, especially about the patient if they combine with the ECG change. And so this will be a possible tool so we can do the early screening. But if we were to do the really nice diagnosis, and so this is a possible risk score we can apply in our patient, especially if the patient have active lymphoma, and this is to be associated with the myocarditis here, and also the change of ECG and the increase different kind of level of the troponin. So calculate this, and actually you can differentiate the risk of patient who can possibly have the incidence of the myocarditis. So the diagnosis actually currently because the cardiac MRI is more prevalent to be used. So cardiac MRI will be sometimes we can use to replace the myocardial biopsy, which is more invasive. So here, if we get the clinical history and there's the treatment of immune checkpoint inhibitor, and later on there's the symptoms also combined with a confirmed diagnosis cardiac MRI, even we can do the definite diagnosis about that. Otherwise, we can use the echo combined with symptoms and biomarkers, the ECG, and the negative angiography. All these combined together could also possibly make a definite diagnosis. So this is the cardiac map, which can show that we can use the LGE or like LFT tool, and we see the significant enhancement of this. And this is the clue about the myocarditis. So what's the next step? If we make a diagnosis, because the treatment of the immune checkpoint inhibitor induced the myocarditis is very different from the virus-induced myocarditis. So depends on different grades. Sometimes actually we have the pump to the treatment. So we'll use like a high dose, even like a pulse therapy of the steroid. Or otherwise, the other different kind of immune suppressant also can be applied in the different IRAE. So different from the virus, sometimes we can need to use like a immunoglobulin or the other kind of antibiotics. But for this, and actually the highest dose steroid or like immunosuppressant will be the key, and the early intervention will truly change the outcome of this patient. So I think this the most important thing is to combine the oncologist and also with the cardiologist, because once the team can make the decisions, if the patient truly have this kind of diagnosis, so the pump treatment will be very important for this patient. And the other things about the challenge. So because if a patient really need the immune checkpoint inhibitor, possibly will be the last line about the treatment. So if the patient has survived after the myocarditis, the challenge will still be an issue, and possibly currently still has a positive comment about that. If that's the only possible treatment, if the patient is truly recovered, currently about the challenges still have an option for this patient. So this is the guidelines that reviews about the flow chart about how we can treat this patient. So like here we can see the pulse therapy about steroids still at the first line, and the second one will be immunosuppressant. It depends on different kind of symptoms of this patient. So I think this is the end. I just quickly want to share the information about in Taiwan. So actually we pay attention about these kind of IRAEs, and the different kind of centers have been calculate what is kind of the incidence. But I think here we just focus on the cardiovascular toxicities. So this is from my hospitals, the Achievement Medical Centers. This is from 2015 to 2017, and they actually include about 580 patients who received the immune checkpoint inhibitors. And here, actually, you can find about 3.9% of these patients have the major cardiovascular event, including like heart failure, myocardial infarctions, or like thrombosis. And so older patient, male patient, or the patient treated with lung cancer, liver cirrhosis, diabetes, actually have a high risk of that. And here also, if the patient also had a concomitant extracardiac IRE, including like dermatitis or like endocarditis or hepatitis, will have a higher possibility to have the cardiac complications. And the cardiac complication will make the survival is very different, so have a still strong impact to that. And here I just want to quickly say, because these are retrospective studies, so we currently do this by the chart review. But the chart reviews actually identified the 3 possible patients. Finally, we think it is possibly diagnosed with the immune checkpoint inhibitor-induced myocarditis. But at that moment, during hospitalizations, and this patient didn't get pump steroid treatment. Only one gets the low dose steroid treatment. So I think still got enough. Not enough awareness about this kind of disease, and also still need the collaboration between the cardiologist and the oncologist to early diagnose that. And here is the another studies we just published about actually we still found that about within 1 month, this is a higher possibilities to have the IRAE induced myocarditis. Okay, so then this is the registries. Actually, this is hosted in the UCSF, and I think it's globally also like in our centers we participate in this. This is do the registries about global wide that's immune checkpoint induced myocarditis. Want to see that what is the characteristic about this kind of population disease. So just quickly go to the summary. So I think the IO therapy, or called like ICPI therapies, actually is a very emerging and actually truly change the outcome of the cancer patient. But the IRE will be something that we really pay attention to that. And also the overactive T cells, pre-existing autoimmune, and the cytokine stones will be a possible mechanism to cause this kind of systemic inflammation. And currently still lacks reliable preventions, but early diagnosis will be very important, especially based on the expertise of both the cardiologists and also oncologists. A hydrosteroid and immunosuppressant will be the key. And also that's multidisciplines and multi-institutions effort to understand this kind of disease and to raise the early awareness and the proper management, I think will be very important. And still we have to put more effort on that. So also I want to just so welcome everyone. Next year in Taiwan we will host the efficacy, especially I think we truly will have the cardio oncology sections, and everybody will be welcome. So this is my talk, and I'm welcome to take any questions. Thank you.
Thank you, Dr. Chang. I think that was a very informative talk and comprehensive overview of the immune checkpoint inhibitors landscape. Are there any questions for Dr. Chang? If not, maybe I'll ask her a question. So we see a number. Sorry, Dr. Sombu, are you going to ask a question? Maybe I'll just ask a question. So in patients with immune checkpoint inhibitors, and we do know that in some patients who had a troponin done post-therapy and for whatever reasons that is high, but they are pretty well, the cardiac MRI did not show any evidence of myocarditis. What's your approach to this group of patients?
Okay, so actually I think for I just first I will mention about our experience. I think the troponin or like the other biomarkers, we really do like a longitudinal follow-up. Sometimes just the 1 point the troponin increase, it's difficult to explain that what's the meaning of that, especially if the other clinical symptoms or combined cardiac MRIs or the other echocardiographies cannot give conclusive information. So I think one single troponin will be difficult to interpret. But if we have longitudinal, still increased, and we can find that even go to the fold change, going to like 2 of the fold change, I think that it would be possibly mean something. So I think it's a diagnosis. If we can get endocardium biopsy, can get tissue. Of course, it's a gold standard about diagnosis. But if we want to combine all these informations, I think the cardiac MRI would be the first thing. But the biomarkers or echocardiographies, I think we still have to do the longitudinal follow-up. And but the other things about literature reviews, actually previous literatures and have been reported that if the troponin increased compared with the truly normal, there's no change of the troponin at all, I still have certain kind of risk higher, but it's still difficult to say if it's referred to myocarditis or the other possible complications. Just means that we have to pay more attention about this patient. Thank you.
Okay, thank you very much, Chang. I think that's a very real point that we need to further evaluate, especially also given that troponin I is supposed to be a bit more sensitive for this group of patients as opposed to troponin T because of co-reactivity from myopathy as well. Maybe in the interest of time, we'll move on to the next speaker.
Okay, so let me introduce. Should we shift to the? Okay, good. Okay, so today it's my honor to introduce my co-chair. So it's Dr. Andrew Kongtown, and from Singapore, and he is a senior consultant of cardiologist in National Heart Center Singapore, and he is also assistant professor in the Singapore Duke and NUS Academic Medical Center. So today his talk is about the biomarkers, just as the question he asked me, biomarker and the cardiovascular outcomes in the CAR-T, in OR and in ALL and lymphoma. So cytokine release syndromes. So please.
Thank you very much, Dr. Chang. I think you set the stage for immunotherapy and it makes my job much easier. So my name is Trenta, I'm based in Singapore. So today I'm going to talk about CAR-T related cardiac complications. So I aim to give you a brief overview of what CAR-T therapy is about, the prevalence spectrum, as well as mechanism of cardiotoxicity that's related to CAR-T cell therapy, followed by approach to managing patients with pre-existing cardiac issues who are being considered for CAR-T cell. So in the past century or so, surgery, radiation therapy, and chemotherapy have been the mainstay of treatment. But come 1990s to our recent years, targeted therapies as well as immunotherapy have taken center stage. As Dr. Chang has previously mentioned, immunotherapy are immune checkpoint inhibitors as well as CAR-T. They are forms of immunotherapy that can be used in cancer patients. And what exactly is CAR-T cell therapy? This may be foreign to us cardiologists, but what it actually represents is that if you remember your younger days when T cells are actually fighter cells in our immune system. And CAR actually stands for chimeric antigen receptor. This is a receptor that's added to T cell to form a CAR T cell to help to fight cancer cells and kill them. So what the procedure entails is that blood is first removed from the patients to get T cells. These T cells are actually manufactured in the lab through a process whereby the chimeric antigen receptors are added to the T cells, and these are grown in the laboratory before being infused back to the patients to help to kill cancer cells. And in terms of the indications for CAR T cell therapy, is mainly limited to solid tumors like lymphomas, your myomas. However, there are ongoing clinical trials to for instance, in the various cancers to see whether they can be used. Even for patients with HIV, patients with heart disease, there's some evidence that certain types of CAR T cells may be useful. And because CAR T is an immunotherapy, it elicits an immune response that affects the whole body, can affect the hepatic system by causing transaminitis. It can cause a whole host of hematological disorders, neurological disorders like headache, change in conscious state. Constitutional symptoms are central to CAR T cell therapy, which means most patients with some form of fever, lethargy, anorexia, arthralgia, fatigue. In terms of cardiovascular complications, we'll delve into them in deeper in the next couple of slides. So the proposed mechanism of cardiotoxicity due to CAR T cell therapy can be direct, which means it's due to T cells, because of cross-reactivity between the T cells on the CAR T therapy and perhaps titin, which is actually a myofilament in cardiac tissues. Or it can be indirect, that means that it's cytokine related. And this is the main way that it exerts its side effects. So with cytokine release syndrome, post-CAR T, that's a bit similar to a cytokine storm, whereby there's vasodilatation of the vessels, there's capillary leakage, there's fever, there's multi-organ dysfunction. And what it causes is things like hypotension, shock, myocardial infarction, thromboembolic events. It can also cause a worsening of LV dysfunction, right heart failure, arrhythmias, for instance, atrial fibrillation, or even sudden cardiac deaths. So in terms of the toxicity of CAR T cell therapies, it occurs in almost 20% of patients going for CAR T therapy. So CRS is the overall arm to say which encompasses neurotoxicity and cardiotoxicity. So as you can see, 9 in 10 patients who have some form of cytokine release syndrome. That also could be a suggestion that the therapy is working in the body. In terms of the median time to toxicity, it varies usually in the first couple of days, the first 5 days or so, post-CAR T infusion. And you can see in this, basically it shows that the number of reports, for instance, in patients with cardiogenic shock, it carries a very high fatality rate of up to 81%. Whereas things like tachyarrhythmias, AF, and all this, it has a fatality rate of 36%, which is by no means low. So it's actually a high-stake procedure or treatment. Again, you can see that the various onset of tachyarrhythmias, cardiomyopathy, cardiogenic shock usually occurs in the first 5 days of treatment. And we need to know how common are these cardiac complications. So we look at various registries, and these are the various CAR T treatment over here that are commercially available. You can see that heart failure occurs in up to 28% of patients, or rather depressed heart function. Troponin elevation occurs in more than half of the patients, and arrhythmias, of which atrial fibrillation is the most common cause, can occur in less than 5% of patients, and cardiovascular death in 4% of patients. And the grading of cytokine release syndrome is best graded by AST/CT criteria. So basically, this is a consensus statement. Central to any cytokine release syndrome is the occurrence of fever above 38 degrees Celsius. And depending on whether they have hypotension or hypoxia, they can be graded grade 1 to 4. So just to give you an idea, 4th is severe hypotension requiring multiple vasopressors, as well as mechanical ventilatory support. And the treatment of this group of patients is actually supportive in nature. So for these recommendations, they recommend that anyone with grade 2 and above, you should monitor cardiac function as well as other organ function closely. And those with grade 4 should get an echocardiogram. Treatment-wise is this IL-6 antagonist called tocilizumab with or without steroids. So there's a protocol based on the grade of the cytokine release syndrome, whether we administer things like IL-6 antagonists or steroids. So because of the side effects of CAR T cell therapy on the heart, there are some recommendations that, for instance, the European Bone Marrow Association suggested that all patients going for CAR T should have a baseline echo to make sure that EF is more than 40%. They have a baseline ECG to exclude significant arrhythmias. Biomarkers is good as a baseline because, as the previous speaker also mentioned, sometimes we trend biomarkers to see the effects of treatment rather than a one-time point in the treatment course. And can you consider cardio-oncology review for further assessment of treatment suitability and scope for cardiac optimization for at-risk patients? So this is also a protocol or recommendations that touches on what to do as a cardiologist pre, during, and post. Pre, checking baseline troponins, NT-proBNP echo, and consider referral to cardio-oncologist for further optimization if your ejection fraction is less than 50% or there's baseline elevation of troponins. As side effects usually occur within the first 5 days, we monitor the heart rhythm of the patient. In high-risk patients, you may consider surveillance of troponins or NT-proBNP at day 7. And if there's any of these, for instance, a sustained atrial fibrillation, hypotension, a drop in cardiac function, or artery dysfunction, we may want to get cardio-oncology involved. For patients post-CAR T without a non-complicated cause, usually a review in 3 months will suffice. But for patients with cardiotoxicity, it's recommended that we review them earlier in the clinics to see what we can do for this group of patients. There's also a role for biomarkers like troponins for cardiovascular prognostication in CAR T cell therapy. So we know that in patients with cytokine release syndrome, if it's grade 1 or no cytokine release syndrome, regardless of whether there's troponin elevation or not, there's no subsequent cardiovascular events. But anyone with grade 2, 3, or 4 cardiac events, if you have a troponin elevation, that actually predicts a risk of subsequent cardiovascular events like mortality, new heart failure, new arrhythmias, as well as heart failure decompensation. If patients have a grade 2 and above cytokine release syndrome, but no troponin elevation, the risk of subsequent cardiovascular events are low at less than 4%. I wanted to give you a few case scenarios that you may encounter in your practice because we wanted to make it as educational as possible. So if the oncologist refers us for assessment of cardiac suitability of CAR T therapy, what do we do if there's, for instance, a baseline atrial fibrillation, atrial flutter, or even before you start therapy, the heart function is reduced? We'll talk about atrial fibrillation first. We know that the risk of atrial fibrillation in cancer patients is increased. Cancer patients have the highest risk of being diagnosed with atrial fibrillation within the first 6 months of diagnosis of cancer. And this could be because of increased contact with the healthcare system. It could also be because cancer, as well as atrial fibrillation, share common pathophysiological pathways, for instance, an increase in oxidative stress. And we know that atrial fibrillation in patients undergoing CAR-T occurs in around 4% of patients. So that's the most common arrhythmias, regardless of the type of CAR-T cell therapy that is being used post-CAR-T. And not only that, atrial fibrillation may be associated with increase in major adverse cardiac events in patients undergoing CAR-T. For instance, the presence of atrial fibrillation is associated with almost a 3 times hazard ratio of MACE compared to patients without atrial fibrillation. Hence, it's important for us to recognize the presence of atrial fibrillation. In terms of how we manage, that would be basically how we manage in our patients. But for patients in cancer, you have to consider, for instance, the bleeding risk, the risk of thrombocytopenia, the risk of coagulopathy, especially in patients with lymphomas, with hematological disorders. They may have deranged, for instance, thrombocytopenia, they may have anemia, and that may make the use of anticoagulation a bit less appropriate. Symptom control, as well as cardiovascular risk factors monitoring. There's unfortunately no data in how do we prevent, or how is there any role for prophylaxis in patients going through CAR-T. But we borrow the evidence for patients going for cardiac surgery, and this Papa Bear study, it shows that if you give prophylactic amiodarone, that actually reduces the post-operative risk of atrial tachyarrhythmias. In some instances of patients with very refractory atrial fibrillation, we do preemptively give them, for instance, amiodarone or any rhythm control agents to reduce the sequelae of them having tachyarrhythmias. Because bear in mind that cytokine release syndrome causes hypotension because of vasodilation on the vessel. So you don't want to end up in a situation whereby patients are running a fast heart rate, patient is very vasodilated. That's going to cause the blood pressure to crash. In terms of experience of treating patients with atrial fibrillation, we have patients, for instance, this 69-year-old patient with follicular lymphoma who underwent CAR-T. He had metoprolol prior to CAR-T therapy, as well as amiodarone peri-CAR-T. He only developed grade 2 cytokine release syndrome. And the other patient, 68-year-old male, after transplant had atrial fibrillation even before CAR-T, also managed to get by CAR-T with minimal sequelae because just some tocilizumab steroids. The other question that we get asked is that, what if the heart function is really poor prior to the commencement of CAR-T? There's not much of data, as CAR-T cells in their registration trials excluded patients with cardiomyopathy. And not only that, the use of CAR-T therapy can also cause the heart function to drop. So you can see these are the registration trials with different types of CAR-T therapy. As part of the trial design, they excluded patients with a drop in ejection fraction of less than 45% or had recent cardiac events. So do not know much about this group of patients. In terms of post-marketing surveillance, we know that even in those patients with a normal ejection fraction or near normal ejection fraction to begin with, almost 28% will get a drop in ejection fraction. And the risk of, for instance, heart failure or cardiomyopathy will be in the region of 5% or so. The good news about the drop in ejection fraction during CAR-T cell therapy associated with cytokine release syndrome is generally reversible. So in this group of patients, they actually monitor their ejection fraction throughout CAR-T therapy. Out of the 28 patients, 6 patients had a drop in ejection fraction. And fortunately, 4 out of 6 patients had a recovery in ejection fraction by day 28 post-CAR-T cell infusion. So it seems to us that the drop in ejection fraction post-CAR-T cell therapy might be a transient event. In terms of our experience with managing patients with underlying cardiomyopathy, we had patients with ejection fraction of maybe 42% or 47% who underwent CAR-T without any worsening of ejection fraction. And the main goals of treatment is to ensure they are on guidelines-directed medical therapy prior to treatment. I wanted to advocate the concept of permissive cardiotoxicity in cardio-oncology because these days is not about saying no to a treatment or not saying that they should just go for treatment without due diligence, but we do comprehensive risk assessment and mitigation. We discuss with our oncology colleagues, our hematologists. We counsel the patients as well as their next of kin before we allow them to go on treatment and do our due diligence and try to monitor them for cardiotoxicity. So what are the risk factors for cardiotoxicity in patients who are undergoing CAR T therapies? For instance, if baseline troponins are elevated, older patients, those with risk factors are hyperlipidemia, coronary artery disease, aortic stenosis, previous chemo, the use of certain medications are deemed to be associated with cardiotoxicity, but that may be due to biases because patients on these medications are deemed to have risk factors as well. In terms of primary prevention efforts, is there any role for cardiovascular medication? And how do we reduce cytokine release syndrome? So there's no data of primary prevention of cardiomyopathy prior to CAR T, but could we extrapolate from our studies on anthracycline-related cardiotoxicity? This is an area that is of active research, which means can we start there on ACE inhibitors, beta blockers, statins? We do not know the answers, but there's active research going on in this area. What about giving them prophylactic IL-6 like tocilizumab prior to their treatment? So in patients with prophylactic tocilizumab in this study, in Cleveland Clinic, was noted that it decreased the incidence of cytokine release syndrome from 35% to 17%. However, there are concerns about efficacy of treatment from the oncology standpoint. As a result, this is not a standard of care. So in summary, CAR T therapies can cause a spectrum of cardiovascular events, be it atrial fibrillation, cardiomyopathy, cardiogenic shock, either through direct mechanisms as T-cell mediated or indirect mechanism mediated by cytokine storm. And we also spoke about screening, monitoring, and managing cardiotoxicities in patients who are undergoing CAR T. So this is an area that we need more research to understand mechanism of, as well as how do we prevent CAR T-related cardiotoxicities. With that, thank you very much for your attention.
Thank you, Dr. Chun Tang. It's really nice talk. Also, actually, I'm quite impressed with the permissive cardiotoxicity. I think it's a good idea that I can use in different kind of cancer treatment, because we are not always talk with my oncology colleagues. We are not doing something against your treatment. We are doing collaborate together and to take care not only the cancer but also the cardio health. Okay, so I'm just wondering that all the questions from the audience. If not, I will take advantage again to ask questions. Okay, actually, this is the things I really want to know that. So if in comparison with the cardiotoxicity induced by the immune checkpoint inhibitor, which I talked about, and also the CAR T. So what's the difference between the prevalence and also the mechanisms and also the possible treatment or outcomes about these two? Thank you.
I think that's a very interesting question. So both are immunotherapy, and my personal experience is that I think things like myocarditis occur a bit less frequently. The majority of the symptoms in CAR T are usually due to the cytokine release syndrome, whereby they get hypotension, they get tachycardia. So the treatment is actually supportive in nature. Supportive in the sense that they are given inotropes, vasoconstrictors in that acute phase. Surprisingly, not so much of myocarditis yet. Either that would be masked by the steroids as well as tocilizumab that's given in the early course of the treatment. It's part of the treatment regime. I think we need more studies to understand that, because the immunotherapy is an area that is rapidly evolving, and even with immune checkpoint inhibitors, there is evidence of accelerated atherosclerosis, soft plaque formation, myocarditis, a whole host of side effects that we are getting more and more these days. So I don't have a good answer to your question.
Yeah, I think still have a lot of things to explore. And so I'm wondering, any more questions from the audience? Okay. Okay, if no, and so maybe we can move to the next one.
Yeah.
Okay.
Okay, thanks very much. Move on to the next speaker, Dr. Syed Fayyaz Muttaba Shah, he's an associate professor at the National Institute of Cardiovascular Disease in Pakistan. And today he'll bring us a clinical approach to cardiovascular toxicity of oral antineoplastic therapy. How do we assess, monitor, treat arrhythmias, LV dysfunction, as well as hypertensive events? Dr. Shah, please.
Okay, let me unmute myself. Thank you. Thank you for giving me this opportunity to talk on this prestigious forum. And let me share my slide. Okay. Can you see the?
Yes.
Okay, good. Okay, so I will be talking about clinical approach basically. My work has been very much also covered by the other speakers who has spoken before me. They have almost covered the topic of assessment and monitoring with the help of investigations like the echocardiography, GLS, and the biomarkers. So my work is now much simplified. So let's start. Just a problem that I am okay. Now can you see this one? Okay, so now just a brief talk about the differences between the older traditional chemotherapy and the newer oral agents as far as the cardiotoxicity is concerned. That basically we are much familiar with the cardiotoxic side effects of the older drugs like the anthracyclines and trastuzumab, and we have got a much robust data about and we know the mechanisms, how they cause the cardiotoxicity, and then well-established guidelines are also present. As speakers before me mentioned, the paucity of the guidelines regarding the new agents that we use in chemotherapy nowadays. And as far as the newer oral agents are concerned, on one hand, they have dramatically changed the scenario of cancer patients, like they are easy to use and then fewer other side effects. But other thing is that we don't know much about their cardiotoxic effects, don't know as much as we know about the older agents. And another problem with the oral as compared to the IV and the traditional one is that because newer agents now affect or target the normal physiological pathway. That is, on one way, it is a good thing that means we are getting efficacious result, but on the other way, the normal physiological pathways are getting disturbed. So many times it is becomes difficult to pick up the cardiotoxicity or the other toxicity, especially at the subclinical level. I will be talking mostly the three topics, that is LV dysfunction and arrhythmias. Most focus will be on the QT prolongation and the hypertension, the oral agents cardiotoxicity. What we know, this topic has been covered much. LV dysfunction associated with oral cytotoxic drugs. What we know that we define it normally that any decrease are more than 10% or decrease below the best value of 50%, we label it as a LV dysfunction or CTRCD. And then most commonly, though, it is associated with the anthracyclines and the trastuzumab, and but the oral agents, TKIs, they are also associated with LV dysfunction, and they do so either by the direct their toxic effect or indirectly by problems like causing the hypertension and arrhythmias. And this is the list of the most common drugs which causes the heart failure, most common oral drugs that are prescribed and cause the heart failure. And it includes all the common drugs that we use. Now, it is always better to screen for the prevention of the disease. And as far as the screening of the patient is concerned, I always say that history is always going to help us, especially in the settings where we don't have the modern facilities and we don't have the use of the advanced technologies because of the cost effectiveness and because of the other healthcare system related things. So it is always better to have some time, take a good history from the patient, and then come out with the risk factors which may pose the patient at risk after the initiation of oral chemotherapy. So most of the times what we know that there are certain high risk features like age more than 60% and history of coronary artery disease or the MI, and history of the arrhythmias, especially the atrial fibrillation, history of heart failure. And if not so, then presence of the cardiac risk factors. Studies have shown that if a patient is at risk or if the patient is having more than 2 cardiac risk factors, then a patient is at increased risk of developing cytotoxicity after the oral chemotherapy. And then this is a simplified version. What we practice is that what we do the ECG at the baseline of each and every patient, baseline echocardiography, and then about the serum phospholipid and hemoglobin A1C, because we live in an area where diabetes is very much pandemic. Almost 1 in 3rd or 1 in 4th patient in our area is suffering the diabetes mellitus. And diabetes mellitus, most of the time even the patients don't know that they are the diabetes. That is why in our setup we do this screening for the diabetes in assessment of the cardiovascular workup and overall. And another important point is that CAC assessment is a good tool, as many patients with the thoracic tumors, they may be undergoing the CT scanning, and then we can simultaneously check the CAC, and it has got a very high and negative predictive value. If the calcium score is low, then there are unlikely chances that patient is having a baseline ischemic heart disease. And as far as the assessment of the cardiotoxicity or the LV dysfunction is concerned, we do at the baseline, and then repeat assessment when the patient is symptomatic. Now, this is something that is cost effective, to pay some time to take the history. If there are certain symptoms of heart failure, then we do the repeat assessment. But even if the absence of symptom does not and the patient is at the high risk of getting the LV dysfunction, then the serial assessment every 3 months is what is recommended. And for the assessment, echo is the modality that is most commonly used. Much has been done and very eloquently and detailed. It has been discussed that how echo is going to help us in the assessment, especially when the disease has happened or during the therapy. It is most convenient, a lack of radiations, cost effective, easy to do, but it has got, of course, there are some drawbacks like in cancer patient, many patients may not have the perfect habitus to get that echocardiography window, and then the reproducibility and the inter-observer differences. And these are the some suggestions that how we can do better quality imaging and echocardiography to get the accurate results. Like for the EF, Simpson method is a good choice, and it gives us the accurate. And then we can use for to get a proper LV assessment, we can get the agents which can enhance the endocardial definitions, and then 3D echo is also an option. like the GLS, especially the role is in subclinical stages, because studies have shown that once the disease has developed, the echocardiography is going to help us. But if you for the preventive strategies like the GLS is better modality. Like in this slide, we can see the ejection fraction is not going to give us as much information as the reduction in the GLS is giving us. So in subclinical stages, and the role of GLS assessment is robust. And of course, the increasing role of the MRIs, having said that, especially in the cases where LV function is about the 50%, and especially in the cases where we want to make a decision whether to discontinue or to continue the drug, then the MRI is going to help us more over the echocardiography. And yes, of course, there is a very good role of biomarkers. Biomarkers, especially, I talk about this negative predictive value. The studies have shown if the troponins are negative, there are less chances that the patient will develop left ventricular failure with the treatment. So this is a simple algorithm. What we do to assess the LV dysfunction due to antineoplastic oral antineoplastic drug that we obtain, baseline ejection fraction, and then we if the ejection fraction is low, we do see for the reversible causes, like if there's the myocardial ischemia. We do the further imaging for the myocardial ischemia, coronary artery anatomy, or the thallium scan or the other tests to tell us if there is a myocardial ischemia because atherosclerotic heart diseases, and then we try to treat that one. And if the failure is there, then is the management. The first line is almost what the guidelines have mentioned: SC inhibitors, ARB, beta blockers, and then we refer the patient for the multidisciplinary approach, where the heart failure management is started. Now, second part of my talk about arrhythmias. One of the important topic about the oral anti-neoplastic drug is that they are related with the arrhythmias. Like as mentioned previously, atrial fibrillation is one of the most common cardiotoxic side effect of the anti-cancer drugs. It is important management-wise too, because I've seen many cases difficult to treat, difficult to respond to the normal management as we do the patients without atrial fibrillation. We manage without having concurrent cancer therapy. And then all sort of arrhythmias can happen. We see the patients with the tachycardias. They can be because of the autonomic dysfunction or the direct effect. But the most important one I would highlight is the atrial fibrillation. Now, this is one mechanism that has been proposed that the oral antineoplastic drug ibrutinib causing the atrial fibrillation. The effects can be because of the direct effect, off-target and non-target effect, basically. And then the end result is the atrial fibrillation. And I also second the opinion that many a times it is that because the cancer itself is one of the causative factor for development of the atrial fibrillation. So even if these anti-cancer drugs are not given, the atrial fibrillation prevalence is high in cases of the cancer patients. But this is one possible mechanism that causes the atrial fibrillation. And how? But as I already mentioned, that management of atrial fibrillation in cases of TKI is like the ibrutinib is somewhat difficult. Why difficult? Because normally we give the non-dihydropyridine calcium channel blockers. They can cause the drug-drug interaction with the drug because of affect at the P450 system, and they can increase the ibrutinib concentration, and that is why then must be given cautiously. And another one is the digoxin that we use most commonly with the atrial fibrillation, but they also have the drug-drug reaction, and digoxin toxicity chances may be increased. So this must be kept in mind. A beta blocker is a safe option, so beta blocker is a good choice to start with. And another problem is with the anticoagulation. Anticoagulation, as we all know, is not simple in cancer patients because this ibrutinib presenting with the atrial fibrillation patients, they also have got inhibitory effects of the platelets, so they are prone to bleeding. And agent to treat like the vitamin K antagonist, we cannot give because of the association with the subdural hematomas. And novel anticoagulant agents, which we normally give in patients without chemotherapy, they lack the data. Again, the issue of the drug-drug interaction is there. So this is chart may help us guide us regarding the management that if a patient is coming with CHEST score is going to help us. Patient may be having a mechanical, because we see many patient cancer survivors going through with all sort of the cardiovascular problem, and they may present with the mechanical heart valves, cardiac thrombus, or there are the increased chances because of the oral neoplastic drugs of thromboembolism. If they got another indication, then of course anticoagulation should be there. But caution must be kept for the thrombocytopenia, coagulopathy, and intracerebral metastasis, and then drug-drug reaction, as I already mentioned. So arrhythmias, VT, also common. We can see with the ibrutinib and with other drugs, there are the chances of the VT very much. And but how this VT is there still not clear. But one theory is that VT happens because of the QT prolongation, but especially in the cases of ibrutinib, we can see the QT interval, it shortens the QT interval. So other than QT prolongation mechanisms must be at role. Bradyarrhythmias less common than the tachyarrhythmias, but they do happen, especially with the crizotinib and ibrutinib drug. And there are certain baseline risk factors that predispose the patients to develop the bradyarrhythmias with the crizotinib, like age and gender, smoking status, and all this. But most important one is the beta blocker concurrent use. They predispose the patient to the bradycardia. But I would highlight more this one, pre-treatment heart rate. Whatever the cause, if the pre-treatment heart rate is low, that patient is prone to develop symptomatic bradycardias. So clinical screening for the pre-treatment heart rate is important. And as I mentioned, that concurrent use of the beta blocker in this study has shown that it decreases the heart rate more in patients who are concurrently taking the beta blocker. And we know that many patients, this is a study, many patients has shown that the concurrent use of cancer patients also use many other drugs too, like some cardiovascular disease, analgesic, and other drugs. They may have got effect on the heart rate as beta blockers are affecting. And then I have highlighted this point, the drug-drug interaction must be kept in mind when dealing with the bradyarrhythmias. Now, QT prolongation, we know that many oral neoplastic drugs prolong the this QT, and of course, nalotinib are the notorious one. Of course, there is a warning for the sudden cardiac death, though it does not prolong the VT so much, but there is a there is a chances of QT prolongation with these drugs. And another from the practical point of view, many times QT prolongation patients are referred from the cancer department. They have got electronic ECG recording, and then QT is shown to be prolonged. They have got mostly, they do it with the method like the Bezet's method that is most commonly employed, that is inbuilt, and then but that is shown that it has got a much variability and not much reliable. So what the guidelines say, that the Friedrichia method of correction of the QT segment must be employed when assessing these patients. As I mentioned, nalotinib, though it does not prolong the QT so much, but it is associated with the sudden cardiac death events. And amongst these agents, ventricular is the most one that prolong the QT most of the time. But it is, practically speaking, it is associated less with the adverse ventricular tachycardias. If there is a QT prolongation, how we are going to manage? As I mentioned, there is always importance of seeing that what other patient is taking the medication. We know that antibiotics are commonly prescribed, taken by the patients who are on the anti-cancer treatment. They do take psychiatric medications and antiemetics. So they may have the effect, and stopping them or finding some alternative to the medications which do not prolong the QT interval is a good idea. And if you cannot stop, then close monitoring of the QT interval is essential. This is algorithm that is going to help us about if the QTC is increased, then you have to check at what level it is increased. If it is increased to a significant level, then correct it with the correct formula. Friedrichia should be used. And even if it is QT is prolonged, then check for the electrolyte imbalance and correct the electrolyte abnormalities. And then again check for the QT prolongation, and then you define management plan. Of course, you have to recognize the symptoms of the arrhythmias. This is a flowchart for management of the arrhythmias. You have first to recognize the symptom, and whether the patient is complaining of any dizziness, any palpitations. You have to do the ECG, electrolyte imbalance, and then review the patient's medication. Then second thing is that you classify what that arrhythmia is, then check for the drug-drug reaction, and then plan the management. Now, the last part of my talk is about the hypertension. I will just be rushing through my slides. That hypertension is associated with the oral neoplastic agent. Mostly, it is the vascular pathways, signaling pathway associated drugs that causes the increased chances of the hypertension. And especially if the patient is having renal cell carcinoma, one study has shown that the increase of the systolic blood pressure. And one more thing is that the effect may last for a good many years. It may never return to baseline in some group of the patients. And if the blood pressure is developed during the therapy, it may negatively affect. Means sometimes we have to change, or we have to think about changing the anti-cancer treatment about that patient. Now, this is one mechanism that why there is a prolonged blood pressure in the vascular signaling pathway mechanism. There can be because of the endothelin effect, nitric oxide, and then other at the capillary level effect. But one point is to highlight is that the white coat hypertension, which was found to be a significant as far as the patients on the cancer treatment are concerned. So one has to keep in mind about the white coat hypertension. So home-based blood pressure reading is very much important. chances that check avoidance. But the studies have shown there is no significant lymphedema associated if one is checking the blood pressure at home. This is the most often question asked by the patients. And then white coat hypertension must be in mind. And if the home-based reading is there, then the blood pressure of 130 by 80 is the definition of the hypertension. And if at home blood pressure is recorded, then it must have got a recording for the heart rate too, versus for the arrhythmias. Now, thank you. Thank you.
Thank you very much. I think that was a very comprehensive overview. I think you were tasked to give a lot about the whole spectrum of antineoplastic agents. And I definitely thought it was a really good summary of all the things that we should watch out for as a cardiologist when we see patients with oncology issues. Are there any questions that from the audience? Or if not, I think we'll ask Dr. Chang to have the conclusion speech.
Okay, good. Actually, it's about, I think it is a lot of information. Actually, I should give you a 2-hour about lectures, to give the talk about every details. But I really appreciate all the speakers today. So today, actually, I just want to give a brief summary about the 2 hours information we got. Actually, first we found the speaker from Thailand, the Dr. Sitalo, actually give a very nice, comprehensive introduction about how we can apply 2D echo spectral trackings as a monitoring the patient who possibly have CTRCD. And also the next speaker is the speaker from UAE, and Dr. Abu Galadar. And actually, he's gave a very age technique about the what radio oncologists can do today, and including like protons and different kind of MR-based techniques, so that we can prevent the possible cardiotoxicities in our patients. And the next one will be me. And actually, I talk about the image checkpoint inhibitor-induced myocarditis. And also the Dr. Chong Tang from Singapore. So this is my co-chair. Actually, he gave very nice, comprehensive introductions about the CTRCD. And also we give a brief introduction about the comparison between the image checkpoint inhibitor and also CTRCD-induced cardiotoxicities. And the last one is the Dr. Fayyaz Mutabras from Pakistan. Actually, he gave a very nice brief talk and introductions about the possible cardiotoxicities, including like LV system dysfunctions and also arrhythmias and also the hypertensions. So I think we all learned a lot today, and I really look forward to all the possible events about the cardio-oncologists, which is I think is needed more, including like doctors from different expertise and to work together, and so that we can take care of these patients, especially the patient that possibly have cardiac complications. So I think all of us enjoys today's webinars, and I really look forward to the next sections. Thank you.
Thank you all for the presentation. Thank you. Thank you for everyone's contribution.
Thank you.
See you.
Thank you. Bye-bye.